Hi, everyone. My name is Celeste Sandoval, and I wish you all a pleasant morning, afternoon, or evening, wherever you are, and welcome you to this webinar today on operationalizing new generation condom programming, which is brought to you by the Global HIV Prevention Coalition Secretariat, UNAIDS, UNFPA, and the Global Fund. The webinar will last for 90 minutes. Some housekeeping rules. You will see the chat window and the Q&A window active in this webinar. Please, let's use the chat box for introductions, which I encourage you to do by typing in your name, organization, and location. Also for comments as we go along, and for possible technical issues that IT may be able to be of help. Let's use the Q&A box for questions, and in doing so, please direct them to specific panelists for ease of moderation and response. If we have time towards the end of the webinar, you may raise your hand to ask questions during the discussion, specifying to whom you are directing the question. All presentations will be in English, with interpretation in French and Portuguese. Please find and select the language you wish to follow in the interpretation icon in Zoom. Now, it is my pleasure to introduce to you and turn you over to Namwinga Chintu, Program Advisor at UNAIDS. Over to you, Namwinga.
Good afternoon and good morning. And I'm not sure if there's anybody in the evening, but wanting to welcome you all to this webinar on operationalizing new generation condom programming. My name is Namwinga Chintu, as Celeste said, and I will be co-moderating with Chris Jones, who I will introduce a little bit later. I just wanted to start by sharing the program agenda with you all. So if you could flash the program agenda, Oria. Great. So we've just started and we're going to have opening remarks from Dr. Paula Munderi from UNAIDS and Susie McLean from the Global Fund. I will then be speaking with you about some data from the Global AIDS monitoring that data that just came out recently. We will then have Rosemary Kindiomunda, who will speak on new generation condom programming, how and why. And after that, we will have an interesting session on applying private sector experiences to expand condom programming. And we'll be looking at the early results from an integrated approach to demand generation and supply initiative in Mozambique. Following that, we will have, if it is not measured, it is not done. And we will have this presented by Maurice Musheke from the Center for Infectious Disease Research in Zambia. And finally, we will have beyond commodity quantification, the CINET as a precision prevention microplanning tool. So we have a very interesting agenda lined up, and we thank you in advance for joining. However, before we join, I would like to invite two special speakers to give us some opening remarks. I would like to invite Dr. Paula Munderi. Paula is the head of program Innovation for Prevention and Treatment in Pediatrics at UNAIDS based in Geneva. The team that Paula leads establishes and strengthens partnerships and alliances to promote HIV prevention agenda, principally through its function as the Secretariat of the Global HIV Prevention Coalition. Paula has had more than 20 years experience working in this response. Paula will then be followed by Susie McLean, who is a senior HIV prevention advisor at the Global Fund to fight AIDS, tuberculosis, and malaria. Susie is an experienced, published, and industry-renowned HIV prevention and harm reduction specialist. She has developed and expanded some of the world's most successful HIV prevention and harm reduction programs, and has a long history of providing services to some of the world's most marginalized populations. So with that, I would first like to hand over to Dr. Paula Munderi from UNAIDS to give us a few introductory and opening remarks. Paula, over to you.
Thank you, Namwinga. Hello, everyone, wherever you happen to be. And thank you for being here this afternoon. It's really gratifying to see so many of you here. I will not be long. It's a pleasure to be introducing this learning session on the Condom Strategic Initiative. Very, very timely because, colleagues, we are not on track to meet HIV prevention targets towards ending AIDS. Our ultimate goal for 2025 is to reduce new HIV infections to fewer than 370,000 per year. We have made progress globally, but not fast enough. We still have 1.3 million new infections annually. But as we presented last week when launching the UNAIDS Global AIDS Update, we know the path that leads us there. And Namwinga will shortly be speaking to some of the data in the Global AIDS Update report. Specifically for HIV prevention, as the Global HIV Prevention Coalition, we are disseminating and supporting countries to adopt a global HIV prevention roadmap as a core strategy for countries to act and to get us back on track to prevent new HIV infection. This roadmap emphasizes condom programming as one of the pillars of HIV prevention. Because condoms remain the most widely used HIV prevention method, and well-planned and well-delivered condom programs are a highly cost-effective investment in preventing HIV. Yet, consistent use of condoms, especially among key and priority populations, the very populations who are most vulnerable to acquiring HIV, was plateauing or decreasing in many countries with significant HIV epidemics. And among the contributors to this are several things, such as defunding condom provision programs, the ensuing costs to users, limited availability and accessibility of condoms, but also gender norms and negative perceptions of condoms as a tool. So it's against this background that we were really privileged to co-lead the Condom Strategic Initiative with support from the Global Fund, aiming for strengthened national condom programs in 4 focus countries. And we are very happy to be sharing with you this afternoon some of the learnings from this initiative, which has been going on for 2 years. With this, I'd like to hand you over to Susie for her opening remarks.
Thank you, Paula. Susie, are you on the call? I'm not sure I see Susie.
I don't see her connected either.
I think what we will do is thank you very much, Paula, for those opening remarks and for framing the discussion and helping us to understand where we are and why it's so important for us to continue to talk about condoms. And we shall come back to Susie once she comes in to give her remarks. At this time, I would want to hand over to Chris Jones, who is my co-moderator, and Chris brings 25 years of experience as a strategic leader with implementers' instincts. Much of the time Chris has been around supporting design implementation for HIV prevention programs, as well as condom programs in partnerships with funders and national governments. And Chris will be co-moderating with me, so I want to hand it over to Chris to take this through the next sessions, and thanking Paula again. And once Susie comes on, we will incorporate her. Chris, over to you.
Thank you, Namwinga. Pleasure to see you all here again. I work with Man Global Health. It's great to see friends and colleagues on this call that I've come to know over the last 20 plus years I've been supporting condom programs. We've seen a lot of change over the past 20 years, and we're going to have some sessions that focus on some of that change, but also some of the promising developments we see in condom programming. It's wonderful to see this renewed interest in a proven effective intervention to prevent HIV and AIDS, but also STIs and a proven family planning method. I want to encourage you all, as we said in the early moments of the call, to make sure that any questions that you have, please jot them down in the chat, and we'll do our best to address them as time goes on. But we'll also have some time specifically for Q&A as well. So we're going to kick off the presentation by going back to Namwinga, who will share the global perspective of condom programming. So Namwinga is going to orient us to the current state of the programming, providing an update on the epidemiology and condom use trends. She's also going to introduce the updated strategic priorities or pillars recently launched by the Global Prevention Coalition that underpins condom prevention programming, as well as prevention programming overall. So over to you, Namwinga, for the first of a series of what we hope are to be informative and engaging presentations.
Thank you. I see Carla Rodriguez is here from the Global Fund, and Carla, are you able to give us some Susan, are you able to give us some opening remarks, please? I see her hand up there. Thank you.
I think I see that Susie is on the call, but on a different link, so she may not be able to speak, Namwinga. What I would suggest is you go ahead and provide your presentation, and then we'll see if we can get Susie back online to a speaking link.
Great, wonderful. Oria, if you could kindly share the slides. Are these in presenter mode now? Great, excellent. So thank you again, everybody. I am going to share with you some of the data that we've been seeing on condom programming, and build up a story on how, on how this can be used as considerations for condom programming. Could I have the next slide, please? So we heard in our opening remarks that, we're not quite there yet. And this is data from the that just came out last Thursday, that's showing that as of 2022, we still have 1.3 million new infections occurring, which is a significant amount. Could I have the next slide, please? And when we look at this and we drill down into a little bit more detail, we can see that this translates into about 3,600 new infections in adult and children every single day. Again, as we heard, this is way too many infections to be happening in 2022. We drill a little bit further down and we can see about 50% of those are in sub-Saharan Africa, and about 3,200 of those infections amongst adults aged 15 and older, of whom almost half are women. So we are still having infections, and we can see where they're at. Could I have the next slide, please? Just putting this into a more geographical sense, as we had said, majority of the infections are in sub-Saharan Africa, but we can see globally that there are still infections, new infections that are happening on a daily basis. Next slide. Again, now putting this into a global perspective, and we're looking from 1990 to 2022, and looking at these with the 2025 target in mind, we can see there that we have gotten there, but we still need to bend this curve quite steeply in terms of preventing new infections, if we are going to get to the 2022, 2025 targets. So we still have a lot of work to do to get to the global targets. Next slide, please. So what about condoms that we've been talking about? This is an interesting slide that many of you may have seen before, but it tells us about the impact of condoms, and it's looking at scenarios under 3 different situations, where we have a constant 2029 coverage for all the intervention, where we have condom scale up, and all interventions at a 2019 coverage as the light blue one. And we can see in the orange one, if we scaled up all interventions to the 2025 target. So we can see that condoms do have an impact on new infections, but condoms on their own are not sufficient enough. So condoms play a role, but condoms on their own are not sufficient enough. And as we also heard in the opening remarks, that condoms remain the backbone and are easily accessible. And we can see the impact here of condoms. Can we move to the next slide, please? Again, we spoke about the HIV 2025 prevention pillars, where we're focusing to getting down to 370,000 new infections per year by 2025. And these are the pillars that have been outlined in the HIV 2025 prevention roadmap. And we can see there that condoms have been signaled as one of the key pillars, and promotion and distribution of male and female condoms has been recognized as a way that countries need to support to bring down new HIV infections. And this is taken from the HIV prevention roadmap 2025, signaling that this is something that we need to pay attention to alongside the other pillars if we are to reach fewer infections. Next slide, please. Again, looking to the global prevention scorecard as a guide to look at how we are doing around condom programming. This is from the GPC 2022 scorecard report, and you can see the color coding there. Red meaning very low, and green meaning very good. We can see here, particularly around condom use for non-regular partners, we can still see that there's still gaps, amongst many of the countries on that indicator. We can also see, when we look at percent of condom distribution need that has been met, also a lot of gaps. Ideally, if condom programming was strengthened across these countries, there should be a lot more green than red. So again, telling us that gaps still persist in condom use, and we still, the condom programming situation is still in crisis. We still have a ways to go. Next slide, please. Just looking a little bit more now at what we are seeing. Again, this is data that came from the HIV prevention roadmap survey that was announced earlier this year. And it tells us here that we have 33 countries reporting into this, but we can see out of those, only 15 of them reported as having set targets in condom programming. So again, it's something that we need to support countries to be able to develop these targets, and it needs to be a focus area. We can also see that the other pillars are also still not where they should be, but I just wanted to focus here on the condoms to say that we are still not reaching those targets, and countries are not setting targets for condom programming, something that needs to be strengthened. Next slide. Just looking again, this is data from our data for impact team here at UNAIDS, and looking at condom use at last high sex. This was looking at 2 regions, mainly the West and Central Africa region and the East and Southern Africa women amongst females aged 15 to 24. If we, for instance, take the ISA region, we can see not much has changed over the years. And if we look at the Western Central Africa region, we can see that there's actually been a decline in condom use at last high-risk sex. So again, just setting the stage of where a condom program is going at a regional level. Could we have the next slide, please? This slide again shows the global medium condom use at last sex amongst key populations and their targets. So we can see the key populations set out there, and we can see the 2025 targets as the red dots. None of the key global, global medians have reached, where they should be, apart from sex workers, which is getting there, but not where it should be. And we can see people who inject drugs being the least. But again, the point being that with regards to condom programming, we're not where we should be. Next slide. Again, this is looking at medium condom use at last sex among sex workers, and this is now just by region. Again, this shows us using the 2025 mark as the target. Again, this shows us that there's been remarkable progress, but there's still work that needs to be done, particularly East and Southern Africa and Middle East and Northern Africa. Again, just highlighting the importance of disaggregating data and looking at subpopulation data, even for condoms. Could we have the next slide, please? Again, when we look at this and disaggregate this data by, medium condom use at last sex amongst gay men and other men who have sex with men, we see the same trends. We're not reaching the 2025 targets, and more needs to be done to understand why, and also to improve programs to get there. The next slide. The last one, also looking at condom use in people who inject drugs by region. And we can see in this group, we're really very far from reaching the target. And in some regions, we don't have any data. Let's move on to the next slide. So what is this data telling us? The data tells us that trends show reductions in new infections, but as we saw, this is not happening fast enough. Our condom programs still remain a critical component of HIV prevention. They're accessible, they're cheap, and they're effective when used correctly. As I mentioned earlier, our condom programs are still in crisis, and gaps in condom programming, despite many years of implementation, continue to persist. Subpopulation data for condom programming is critical. It informs our programs, and we need it. And our data on programming needs strengthening. We'll see a presentation coming upwards that says if it's not measured, it is not done. We need to strengthen. Data on condom programming. More differentiated, equitable, and people-centered approaches are needed in condom programming for us to achieve our global targets. And I think that was my last slide, and just to set the stage for what's coming next. And I would like to hand over back to Chris.
Thanks, Namwinga. Just checking in. Susie, are you online and able to say a few words of introduction? And if not, we'll go straight to Rosemary.
Hello, Chris. I am online. And hello to colleagues around the world who are interested in condom programming. It's great to be amongst condom specialists. And my thanks to Paula and to Namwinga, Paula for her opening remarks about kind of imperative for condom use, and now Namwinga for the kind of state of the art, if you like, on condom access, condom programs around the world. I just want to say three things, and I'll be brief. I was here, but I was on the wrong link, I think, just to welcome everybody and again say it's great to be amongst condom champions. For the Global Fund, condoms continue to be a really important priority for our funding. We procure a lot of condoms, many millions of dollars worth of condoms that we procure, either directly or with global funds, governments themselves procure. But one of the things that we learned quite a while back as part of the Prevention Coalition was that it's insufficient from a financing perspective to just pay attention to the numbers of condoms procured, but that what was really important for us as a financing agency was to ensure that we were funding condom programs, not just the commodities themselves. I think a good comparison for people is to reflect on the fact that we don't just buy ART or procure ART, we also invest in ART programs, so service delivery platforms, human resources, data systems, etc., etc. And in a similar way, we think that our financing practice can improve by investing in condom programs. And so the Condom Strategic Initiative, a couple of people have mentioned it already, was an effort in 4 countries to try to improve our investment approach and work with country stakeholders to strengthen the program from which the procured condoms are delivered to people who need them most. And the 3 areas that have been a really important focus for us all, including at the Global Fund, has been the program stewardship and coordination efforts. Related to that, the data systems for condoms. Do national program managers know about the number of condoms that have been distributed in different parts? Do national program managers know about condom access issues? And then the 2 other areas that are really important for us is about the last mile supply systems. So we know that often condoms get stuck in warehouses or indeed get stuck at health facilities. And we know that people need condoms well beyond health facilities, in bars and brothels and bedrooms and more informal places. And so an interest that we have in strengthening the systems to get condoms to the last mile. And finally, the area that we're most interested in supporting is demand creation for condoms. And we know that there are many new opportunities in the demand creation space because of online service delivery. And the only other thing, and so we're really interested in countries, people, organizations that want to improve and expand demand creation for condom programs. And one of the things that we've learned along the way in the last few years is how important it is to pay attention to prevention choices, one of which is condoms. And so we think for demand creation, there's some really important imperatives around, where appropriate, not single product demand creation efforts, but kind of ideal that we're wanting to support is where demand creation efforts offer people a range of options, including, for example, self-tests, PrEP, clean injecting equipment, and condoms and lube, so that the kind of prevention portfolio of options is available, and that demand creation focuses on the range of prevention options, including condoms. Final thing I wanted to say, and then I'll hand back, is just to say many of you will have known, if you've observed our funding guidance for the current grant cycles, Global Fund Grant Cycle 7, is to know that we've positioned condom programming as a program essential, alongside a whole range of other program essentials. But importantly, it's the first one on the list. We really want to demonstrate with the program essentials that there are many, many things that the Global Fund can fund under the banner of HIV programs, that we thought that these essentials needed to be really well established and well in place. And the first essential that we've identified as a fundamental element of a national HIV response is a strong condom program. So I hope that program essential has been useful for those of you who are championing the need for attention to condom programs at a country level. And with pleasure, I hand back to Chris and Namwinga for the rest of the discussion.
Thanks so much, Susie. You bring up a really important point around this idea of a need for an integrated approach to condom programming that looks at the growing array of choice that are currently available to users, including different options for PrEP, as well as the established interventions such as VMMC, and the important role that condoms play within that. And it's great to see that the Global Fund continues to focus and prioritize condom programming. And I understand that there's a lot of innovative new interventions that are currently being designed and funded as we speak in the new funding round. So it's great to see that. We're now going to turn to Dr. Rosemary Kindiamunda, a sexual reproductive health and HIV specialist with UNFPA, who plays an important role in supporting the Global Fund supported Condom Strategic Initiative that Susie was just alluding to. Lots of lessons are being learned from the Condom Strategic Initiative, and Rosemary is going to outline some of the challenges that we've seen in the implementation of that program, but also some of the important lessons learned already from that initiative, which is still in its relative early stages of programming. So Rosemary, over to you.
Thank you, Chris. Good morning, good afternoon, good evening, colleagues. Chris, I'm not yet a doctor, but I know I'm a condom champion. Right from my high-risk youthful days, I believe I'm here because of a condom. Next, Oria. So it is surprising that at this time, we still ask why a condom, but colleagues, we still ask because sometimes we don't see it. And besides what has been spoken, that it's proven, it's cost effective, it's for triple prevention, and at the nexus of HIV and sexual reproductive health programming, I think what we need to take is that consistent and correct use at high risk sex is really the epitome of choice, as Susie has said. You will not be able to use a condom unless you are informed, unless you have the skills and you have the autonomy as an individual to actually use it. And we believe that by the time you have this for a condom, you have it. You have the capacity for choice across a continuum of interventions. The condom is also a litmus test for our public health systems. On one hand, because largely, especially in the sub-Saharan region, we've looked at the free condom, but it also is one of the few pieces that are a reality for public, private, and community partnerships in terms of even procurement, handling, and access at community level. So the condom is actually a powerful protection choice for the majority. It is largely acceptable, cheaper and convenient, and can be easily integrated into other running health, but also social programs. Next, please. We come to new generation condom programming. And as Susie highlighted, this is an attempt to look at the condom beyond just the process of quantifying and then procuring. And when they ask you, say, yes, we received so many condoms. And from a people-centered perspective, there are many questions that you need to ask and answer before you actually go to the quantification. So who really needs a condom? And here we are looking at the who, what, where, when, and so on. But do they know about it? They need it for prevention purposes, but do they know about it? Do they have the competence to actually look across the options available and make a choice and act on it? Can they access this condom easily? And here you have to apply the inequality lens in terms of education, residence, wealth quintile, and so on. And can they really use it correctly? We still have cases where condoms are being washed and reused. I don't know how effective that is. So is this condom positioned in a package? And then we go to the stewardship difference, as Susie mentioned, because we need a conducive policy and social environment that actually appreciates the role of a condom and positions it where it should be. And then this informs the strategic planning, where we need the evidence of the who as we have already seen, that can then inform the forecasting and quantification, not just going by the population-based data that we used to do in the past, as we will later hear from the Senate presentation. And then the focus on integrated program delivery. We emphasize integrated even when we know that within that package, since we are dealing with a commodity that is delivered through both the public health and the non-public health platforms, you may need approaches that take it as a commodity, but still from an integrated perspective. And finally, as programmers, we need to build community competence if we are to achieve new generation condom programming for new generation users. Next, please. So we bring to you experiences from this strategic initiative that has been running in the countries of Malawi, Mozambique, Uganda, and Zambia. Next, please. Largely from last year until now. And we bring hypotheses that there are two gaps. One is an availability gap, which we think is largely a stewardship bottleneck. And the next one, of course, is the uptake gap, which we have now seen to be more of a last mile distribution issue than actually an individual-based issue. Next, please. We'll take time on this conversation on this slide and make our case that new generation condom programming is feasible, but it needs championing. It needs people who appreciate and position the condom, not from just because it is promoted by global funding streams, but because there is the evidence for it at global, but also at local level. And we need structured stewardship because it cuts across sectors. You will need the multiple partners, and you will need this stewardship at different levels, national, provincial, district levels, because you still need oversight, you still need harmonization and synergies. And yes, you still need the tools, and we have several of them. Some of you are familiar with PSAT, the program self-assessment tool. On the SI, we use the program self-evaluation tool, specifically to focus on stewardship. Then we have the condom needs estimation tool. We have total market approach tools, and some of you may already have seen the condom planning package that should assist you at country level, at subnational level, to actually plan for the condom. Yes, you need up-to-date evidence. I, for example, remember in the GPC proposal, Malawi had a very good piece on the condom because they had fresh evidence from modeling that indicated that the condom was contributing to reduction of infections, I think around 19%, which was giving people the impetus to really focus on it. Susie has mentioned the role of the big funding streams as catalytic anchors. We had matching grants for some countries, but also the program essentials that now signal to countries that, yes, this is an important tool within the options package. We mentioned diverse last mile distribution options because largely for countries that focus on the free condom, there's also been a focus on getting this condom only through the public health channels to the health facility. And we know that it does not work as it should, as expected. And here we have an example from Uganda that has multiple channels for last mile distribution as part of a national policy guidance. We also note that demand creation without the commodity where people need it may not work. And today we will hear more from Project Last Mile about the innovation that set out, first of all, to raise demand, but realized that they need to invest in last mile distribution. We need differentiated integrated program delivery, and we know that it is feasible. We've seen this especially among key population programs, and we know that it can also be feasible, especially for adolescent girls and adolescent boys and young men who already have standalone programs. Communities know better actually what they want, and they can plan for, they can deliver the condom where it is needed as part of a package of options. And from Malawi, we have a very good micro-planning initiative by the Pakachere program that delivers condoms to sex workers. They do their own quantification, which minimizes waste, as we've been doing broadly. Public-private partnerships are necessary, and we've learned that we can exploit different angles. The private sector can support in demand creation, can support in last mile distribution, different approaches. But of course, we know that the private for-profit on condom programming is important. And colleagues in Uganda, they have come together and established a commercial warehouse at national level, and they do pooled delivery to outlets, which is increasing condom distribution and uptake for those who can really pay for the condom. We have an issue about tracking the untrackable. You will see later what we mean by this, but on this program, we tried as much as possible to understand what do we track at output level before we reach the outcome level, which we usually see in some of what Namwinga was presenting to us. And we are working with countries to establish or work within mechanisms that can track the condom. And in Zambia, we have this potential from a National AIDS Commission Management Information System that captures service delivery beyond the routine public health sector system. And finally, domestic financing is possible, especially in our region that has been so dependent on external support. We've seen this in Mozambique, and learning from Mozambique, Zambia has also started to allocate some funding to condom. Next, please. Finally, we have challenges and opportunities that we can exploit. We still say that the condom and lubricants are still stigmatized, and in some areas highly stigmatized. And this affects the entire program, from policy, programming, service delivery points, and even at community level. And the free condom can actually threaten transition sustainable total market approaches, especially when governments insist that they need to procure more and give to everyone who needs, yet there is willingness to buy that can be exploited to transition people to the commercial condom. Free condom commodity handling is an issue in some countries, and it should be factored into quantification and forecasting processes. There is still competition between interventions, which of course impacts choice. And from condom programming perspectives, you need to present the whole package and build people's competence so that then they can choose. In any case, they can do PrEP and condom once they understand why. We sense that inadvertent deprioritization, even from global guidance. For example, that indicator that we have at a country or service delivery point, it may be interpreted as actually the condom not being necessary when someone is taking a particular intervention rather than presenting a package. And yes, we have a high unmet need, and yet low condom awareness, especially now that we are talking of new generation users. So you have latent demand, but you still have many that need to know about the condom and know how to apply the condom. The funding has been mentioned, and this mainly affected social marketing, yet the social marketing component was actually assisting with building condom use lifestyles to win individuals who can afford from the free condom so that it's left for those who cannot afford. I've mentioned the total market approach. It is still in its infancy, there's a lot of investment needed for conducive environments, even at country level, so that we can have more of the private sector getting on board. Major funding streams can do better because we usually compare with how we are able to track one single pill on the ARV platform, but we are not able to know how many condoms are moving, but wait to check whether actually people used them. So this is linked to if it's not measured, it's not done. And we are trying, as we build the condom M&E frameworks, to understand what exactly can be measured at output level before we get to the outcomes. And yes, we have mega trends that we can exploit so that we can package the condom better for new users and ensure that they have the competency to actually access it, even at a cost. Next, please.
Thank you, Rosemary. If it would be good if you could wrap up.
Yes, no. The last one is just for us to link to the global prevention roadmap commitments as we do new generation condom programming. I won't go through this. You will have it as part of the slides. Thank you. Please be smart, play safe, condomize. Over to you, Chris.
Thank you, Rosemary. To all of you, keep the comments coming. We may not be able to answer all of them during this session, but we'll do our best to loop back and follow on communication through email. And it's also great to hear your comments and questions as well, just in general. So Rosemary has highlighted a number of promising approaches and interventions and tools that can be deployed to design and implement next generation condom programs. Many of the tools that Rosemary referenced, I just want to highlight, are available, such as the condom planning package and the condom needs estimate tool on the Global Prevention Coalition website under UNAIDS. Also, many participants here are from countries participating in the South-to-South Learning Network. And I know that we have colleagues on this call that represent the South-to-South Learning Network. It's an important resource that I want to highlight that can connect you to those tools, but also provide the TA to implement. So there are resources out there. We're also, in reference to one comment, we're packaging and identifying much of the learning in a series of best practice case studies that will be released later this year to inform and enable other countries to learn from best practice with your neighbors. So keep those questions and comments coming. So now we turn to Project Last Mile, which is a promising initiative that harnesses the experience and skill sets of a consumer marketing giant, in this case, Coca-Cola, to a public health imperative. Fascinating project, lots of learning there. And I'd like to hand it over to Rushika Shekhar from Project Last Mile to describe some of the exciting work occurring in this space. So Rushika.
Oh, can you hear me now? I was on mute.
Yes, we can hear you.
Confirming. All right, perfect. Thanks so much for confirming, Chris. Wonderful to be with you all, and thanks, Chris, for the introduction and the time today. We're looking forward to share some initial results and learning from a pilot that we recently concluded in Mozambique, working in support of the Condom Strategic Initiative in close partnership and with support of the Global Fund, as well as the National AIDS Council in Mozambique. So just quickly, for those of you who might not be familiar with Project Last Mile, we are a public-private partnership with the Coca-Cola ecosystem and various international donors that serves to look at how to unlock the private sector best practices, tools, and processes that companies like the Coke ecosystem leverage to support health system strengthening. So we are outside of the Coke system. We are not, for example, leveraging Coca-Cola trucks to distribute health commodities, but we are bringing in experts networks from the Coca-Cola system to look at how the Coca-Cola system would approach a distribution or a marketing problem and applying those best practices to public health. So in Mozambique, which will be the focus of this quick session today, we were engaged to look at how to apply that kind of private sector thinking to improve access, availability, and uptake of condoms in Mozambique. So just to quickly set the stage, which I think colleagues who went before me have done brilliantly, many of you might know that Mozambique has a lower level of condom usage than regional counterparts. And I think especially important to note is that while there were massive gains over the last few decades in terms of the overall condom programming, growth rates have slowed over time in Mozambique, as well as we've seen in other countries, especially for certain priority segments, such as young men. So in order to address these challenges, the Ministry of Health and the National AIDS Council have developed a national condom strategy with 3 key objectives. One is strengthening program stewardship and overall management. The second is increasing condom demand. And the third is increasing condom supply. Project Last Mile was specifically engaged to support the second and third pillars and really looking at shifting the approach to apply a more integrated model based on private sector best practices to look at how we could strengthen both condom supply and demand. So when we talk about an integrated model, what does that really mean? I think traditionally in the public sector, when we've looked at demand and supply challenges, many times we see that those are often siloed, that demand creation is approached as a separate work stream and the supply chain and distribution is approached as a separate work stream. The private sector does things a little bit differently, where first and foremost, the consumer is at the center. And the entire demand, the product, the packaging, as well as the distribution is aligned around where are consumers most likely to access a certain product. So for example, young men might have different needs than a family. And how can, first of all, the product be packaged to address the needs of each of those segments? How can we then ensure the product is placed at the right place at the right time to make sure it's meeting where consumers want to access that product? And then making sure that both the demand strategy and supply strategy is making consumers aware of how and where and why to access that product and motivating uptake. So this model and this integrated approach is what we hope to test in Mozambique. So working with the National AIDS Council in country, we designed and tested an integrated approach and developed out a campaign and distribution strategy, initially piloted over just a 6-month period. It just concluded last month. So these are going to be initial results and learnings that we are sharing with you today. So this approach was piloted in one district of Maputo province, Boan district. So we'll share some of the approach as well as the initial results from that pilot that just concluded. So first, to start with the way that we focused on the demand side. So again, before we actually developed out what a demand creation approach looked like, we first wanted to understand what were the consumer needs, as well as what were the current gaps in condom uptake. We also wanted to understand what the total market for condoms looked like in Mozambique, to understand what was happening in social marketing versus the private sector versus the public sector. That initial current reality assessment, where we engaged both with consumers of condoms in Boan district, as well as mapped out the current reality and understood what was happening across other segments, helped us understand quite a few key things. One was that while there had been quite a lot of efforts in social marketing and private sector condom promotion, a lot of the government sector condom promotion had been focused primarily on promoting the educational or health benefits of condoms. So it was much more around, for example, what are the benefits of condoms as it comes to HIV prevention, preventing pregnancy, STIs, etc. And that obviously had been effective. However, what that meant was also that many people were not aware of where they could access, for example, free condoms. What we also found was that where condoms were currently available, I think several colleagues mentioned this in the initial remarks as well. So for example, the bulk of condoms being available at health facilities, we know that young men, which are a target segment for male condoms, for example, are not accessing health facilities and not going there just to access condoms. So from this approach, as well as coupled with what we had seen in terms of the ongoing stigma around condom usage and an overall cost versus benefit analysis between consumers, where they were understanding what the potential health benefits were, but the cost of using.
Sorry, Rushika, could you please slow down a little bit? I got a request from the interpreters that it's difficult to catch up with you speaking too quick. Thank you.
Sure. Thank you so much. Sorry for going quickly. I wanted to make sure we got through this in time. Please let me know if I'm going too quick again. So in terms of the approach taken, we understood that there was a need to promote the overall use of condoms. So the focus was on making sure that there was shifts in perceptions, awareness, behaviors around all condoms. But our core objective and KPI from the demand creation campaign was specifically making sure that there was increased uptake of free government condoms that were the focus of this pilot. So through this entire approach, we developed out a campaign, Faze Ben, which it means do it well, that was modeled on being a more fun, engaging way to promote condoms based on what we heard as the needs of consumers. It was important to make sure that the campaign could promote various different types of messaging. Educational messaging to ensure that the benefits, the health benefits were still reinforced, but also the leisure benefits, the pleasure benefits, and associating condoms with something other than just health and prevention, for example. And this was important, especially as we looked at how to expand the distribution strategy outside of just public health facilities, where we heard from consumers, for example, that if they were seeing condoms available at a bar or a tavern, they might not want to be associating that with HIV at a point where they were thinking about an act of pleasure. And so maybe motivating consumers more with leisure messaging at specific channels and prioritizing educational messaging for other channels. So quickly then going through how we focused on the supply side and the other side of the coin. So on the distribution side, once we had understood what the needs were of consumers, where they most wanted to access condoms, we then looked at mapping out what would be the optimal access points to make condoms available to users where they actually wanted to use them. And our focus was primarily at the last mile beyond the district level. At the beyond the district level, at the last mile, we focused on two key channels. The first was public health channels. That's what we call channel 1. And the second was non-traditional access points. And this was access points outside of the health sector. There were a lot of existing challenges within the supply and distribution strategy that existed that needed to be addressed to make sure that condoms could be available at the quantity needed where people wanted to access them. Many of the challenges, I think previous presenters have also indicated in terms of the lack of data visibility at the last mile, challenges in transport, storage, and being able to actually ensure distribution consistently down to the last mile. So through this pilot, we developed out a route to market and last mile distribution model to execute a segmented channel strategy. What this meant was we first segmented each of the channels that we wanted to service, bars and taverns, for example, versus health facilities, and then looked at what a cohesive distribution strategy could look like for the district. This involved engaging a third-party logistics provider to address some of the primary and secondary challenges involved in transport, for example. We also helped address some of the other challenges involved in, for example, storage, ensuring that the district and provincial warehouses had the appropriate management tools to improve stock control, and ensuring that we could improve visibility down to the last mile to understand how many condoms were being delivered, as well as how many condoms were actually had offtake at the last mile access point. So once they were distributed, how many of those actually left the access point and could be assumed consumed. So just in terms of the results and learnings from this approach, again, this was a 6-month pilot, so we'll be the first to acknowledge that this is a very quick time to really look at generating long-term learnings. But we were very encouraged, I think, to see that even in this initial 6-month period, there were a lot of learnings, as well as some initially encouraging results that we could take forward to help look at how this kind of model could be integrated and made sustainable in future condom programming. So on the distribution side, through the implementation of this distribution strategy, we were able to distribute 1.2 million condoms over the 6-month pilot. About 81% of those were delivered by the 3PL solution that we implemented. There was a 43% increase in the number of active access points that were primarily driven outside the public sector. So a huge mandate of this initial pilot was looking at how to increase access at places that people wanted to access condoms outside of health facilities, and we were able to activate quite a few additional access points to ensure that availability. Overall, we saw about a 240% increase in the monthly condom volumes distributed. At baseline before pilot, there were about 76,000 condoms being distributed in Boan. And by the end of the pilot, it was about 263,000 condoms per month that were being distributed and made available for consumers. I think very importantly, though, what we were especially encouraged by is by implementing the demand creation strategy alongside the distribution model, even though there was a huge influx of condoms into the district, we also saw that there was high offtake that happened over time with condoms. That meant that even though the condoms were going in increased quantities to the last mile and to access points, 75% of those were actually taken up and were being shifted out to consumers from access points. So we were able to address both demand and supply. On the demand side, just to touch on a few key learnings, I think several colleagues have already mentioned some of the concerning trends in terms of reduced uptake of condoms that have been indicated the importance of us continuing to invest in shifting perceptions around condom usage, as well as increasing motivation to actually use condoms. Over this initial 6-month pilot, we were able to see that about 80% of respondents were able to have some awareness of this campaign within the initial 6-month period. And I think importantly, we saw that high awareness also seemed to translate into some initial increases and shifts in perception of condoms. So a majority of respondents in Boan that were exposed to the campaign said that they were somewhat or very likely to change their behavior around condoms after being exposed to the campaign. I think for us, one very encouraging piece was that over the 6-month pilot, we saw that there was a 10% increase in a belief that government condoms were effective in preventing HIV and STDs as well as pregnancy. So just seeing that shift in the importance of prevention and folks starting to understand and believe that condoms could be an effective tool in prevention, and also seeing perceptions and shifts in Boan, the district where the program was implemented, across versus national averages. So seeing shifts and increases in condom knowledge and awareness, as well as perceptions as compared to baseline, as well as national averages. And then just to close with some initial learnings from the model, I apologize again for going very quickly within the short time period. But I think a key learning for us has been that integrating the demand and the supply side can be effective and is integral, I think, for any model that goes forward, that we need to make sure it's addressing both sides of the coin. If we just tackle distribution and increase supply without demand, there could always be a risk of limited offtake and wastage of condoms, for example. So that integrated approach, I think, was critical as part of the pilot, and a key learning of the importance of that. And the second, I think, was that this was a quick 6-month pilot, and we acknowledge that building sustainability and efficacy and efficiency for such an approach will take time. So while there is interest in looking at how this model can be further scaled and integrated into national condom programming prior to any further scale up, I think it's very important to take a more phased approach to allow for more testing of the model, but more importantly, make sure that in the existing infrastructure and partners in country have the capacity and capability to manage both the demand and the supply side in order to integrate that and make it more sustainable in the long term. So thank you all for the time today. And with that, I'll close and hand back to the chairs.
Rushika, thank you very much for your very exciting presentation, and I think we can learn a lot from Project Last Mile's experience on linking using private sector approaches in condom programming. I would now like to introduce Dr. Maurice Mushike, who is going to give us a presentation on if it is not measured, it is not done, and he's looking at tracking the condom on integrated service delivery platforms. So thank you everybody for staying on, and we still have a couple of more presentations. Wanting to hand this over to Dr. Mushike. Musheke, sorry. Dr. Musheke, are you?
Are you able to see me?
Yes, we can. I think you just need to put it into slide mode, presentation mode.
Yes, just a minute. Okay. Just doing it now. Hold on. Okay, this is my presentation.
If it doesn't work, we can have Oria share it for you.
Okay. Okay.
Is it working?
She can.
Oria?
Are you able to see it now?
I think this is Oria.
Oh, that's Oria. Okay. Are you able to hear me?
Yes, we can hear you perfectly. Thank you, Dr. Mushike. Please go on.
All right. Thank you very much. Good morning, good afternoon, and good evening, colleagues. So my presentation basically focuses on showcasing how CIDR's Key Populations Program has been able to deliver, track, and report condom service delivery for key populations. So my presentation is titled, "If it is not measured, then it is not done." Next slide. So my presentation is structured as follows. I'll give an overview of our CIDR's KP program. I'll highlight the burden of HIV among key populations versus the general population. Then I'll talk about our implementation model for HIV service delivery to key populations. Then I'll highlight some of the current challenges and gaps in KP programming, some of which Rosemary already says, of strategies we've put in place to improve access and reporting of condoms. Then I'll conclude by talking about the lessons. Next slide. So CIDR's is the largest independent local non-governmental health organization in Zambia. And our programs basically three domains. We have training and capacity building. We have research, which includes basic research, implementation science, and also vaccine research. But we also have social and behavioral science research. We also have health service delivery and technical assistance as one of our domains, focusing on HIV prevention care and treatment, TB prevention care and treatment, maternal, newborn, child, and adolescent health, but also crucially key populations. Next slide. Allow me now to narrow down to two key populations programs that we are implementing as CIDR's. We have the first one, which is called the Key Populations Investment Fund Program, which is funded by PEPFAR through the United States Centers for Disease Control and Prevention. And this is implemented in 4 districts of Lusaka province. And our implementation is done in partnership with 3 key populations-led organizations and also the Zambian Ministry of Health. And we began implementation of the KPIF program in May 2019, primarily focusing on men who have sex with men, female sex workers, transgender, people who inject drugs, as well as prisoners or incarcerated persons. Next slide. Then our second key populations program falls under a larger HIV prevention project, which is funded by USAID. This project is called the Controlling HIV Epidemic for Key and Underserved Populations, Checkup One project. And this is in the KP program is implemented in 7 districts, as highlighted on the map of Zambia there. And our implementation began in October 2021, focusing on men who have sex with men, female sex workers, and transgender persons. Next slide. For not familiar with Zambia, so as you can see from this slide, Zambia study that was conducted, you see burdened countries insofar as HIV is concerned. We have Lusaka province, for instance, which has an HIV prevalence of slightly over 14%. Copperbelt province, where our key populations program under Checkup One is implemented, has an HIV prevalence of around 12%. Next slide. So when you look at the HIV prevalence in the general population versus HIV positivity in the KP program, you see that HIV prevalence in the KP programs clearly dwarfs the HIV prevalence in the general population. On the left side of the slide, you see that our overall HIV prevalence, our HIV positivity in the CDC-funded KP sites was 30. Checkup One sites where we are implementing the USAID-funded KP program, you see that the overall HIV positivity was 19%. And this underscores the need for effective HIV prevention measures, in this case, condom programming, in order to reduce the risk of HIV infection. Next slide. So how have we implemented our key populations program? It's important to mention that same-sex relationships in Zambia are criminalized, and also the key populations are highly stigmatized. And this serves as a barrier in terms of access to health services, including condoms. And so as a program, both the KPIF program as well as the Checkup One Key Populations program, what we've done to mitigate the challenges of accessing health services, we've set up what we call safe spaces as service delivery points. Next slide. And in these safe spaces, we provide a whole range of HIV services. This includes HIV counseling and testing, the provision of antiretroviral treatment for those that are living with HIV, PrEP for those that are high-risk key populations but HIV negative. We conduct STI screening and treatment, condom and lubricant distribution, family planning for female sex workers, and referrals for other high-impact HIV services. It's important to also mention that in as much as we operate these safe spaces where key populations come to access services, each safe space is linked to a government health facility for data management as well as reporting, but also crucially for our programs to access the commodities such as HIV testing kits, condoms, as well as treatment. Next slide. In her presentation, Rosemary talked about some of the challenges related to condom programming. She talked about the availability up, she talked about the condom act as well. But in addition to that, we also identified the challenge of fear of stigma and discrimination at government health facilities, hence the setting up of those safe spaces in order to improve access to health services. Next slide.
Hello, Dr. Musheke. We would need a little bit more acceleration. Thank you.
Thank you. So how have we improved the uptake of condoms? To address the availability gap and the condom uptake gap, what we've done as KP programs is to conduct hotspot mapping or venue mapping to identify access points where key populations can easily access services. And we've combined that by identifying and training community gatekeepers as condom promoters and distributors. But most crucially, we've also mainstreamed condom promotion and provisions in all aspects of HIV care, either through mobilization and support group activities as viral load testing. So for all these platforms of mainstreamed condom promoter. Next slide. Next slide, please. So our teams constantly conduct remapping of venues and hotspots, as well as routine data collection. So in terms of the tracking, data management, and reporting, as you can see from this slide, we secure our condoms from government health facilities. And these condoms are distributed through community safe spaces, as well as the static AP wellness centers. And in terms of documentation, we use daily activity registers, condom notebooks, condom registers. And then this data is fed into the DHIS2 for reporting to NACMIS, for national reporting purposes, but also for reporting to our donors, in this case, CDC and USAID. And the numbers that we report then feed into the quantifications that are done by the health facilities in order to ensure that there's continuation of supplies of condoms. Next slide. So from this slide, as you can see, there's been an upward trajectory in terms of uptake of condoms. From 2019 to 2023, June, you can see under the CDC-funded Key Populations Program, we've been able to distribute 1.6 million condoms. And for the USAID-funded Key Populations Program, which is less than 2 years old, we've been able to distribute over 200,000 condoms. And we are able to disaggregate the distribution by key population type. Next slide. So what lessons then do we learn? One is that the burden of HIV is high among key populations, but crucially also treatment, whilst it is important, is not sufficient to prevent HIV infection. But as you have seen from our presentation and our data, adaptive programming is key to ensuring improved and equitable access to condoms. And again, condom programming is the easiest and cheapest way of preventing HIV infections. Therefore, the recommendations, mainstreaming from our end is really crucial. Mainstreaming condom programming in all aspects of HIV care is important to ensure that there's improved access to condoms, especially among stigmatized but high-risk individuals such as key populations. Thank you, and I'll end here.
Dr. Musheke, thank you very much for your informative presentation on key populations. I realize that we have limited time available. So without spending too much of your time, we're going to transition on to Wilberforce Muganya from Uganda UNFPA, who is going to give us the last presentation. Wilberforce, do you have your on beyond commodity quantification, the Synod as a precision prevention micro-planning tool. So Wilberforce, we hand it over to you.
Am I audible?
Yes.
Okay, thank you very much, Naminga, and thank you, team. We're going to have a short discussion, really, sharing on to the experiences of Uganda, especially using the condom needs estimation tool as a precision prevention microplanning tool, extending beyond the commodity quantification that is primarily built for, taking opportunity of the processes of applying the CNET to give us an opportunity further to use it for microplanning and extend the benefit beyond just the quantities. My name is Wilberforce Mugwanya, I work with UNFPA, I'm program coordinator to UNFPA Uganda country office. I'll dive into the program. Okay, so with the new global prevention strategy, we're moving to more into precision planning so that we know where the most affected communities are. Just linking from the previous presentation, we know that there are some groups that are affected more than the others. It's important to be more precise with our interventions so that we target them more, so that we can cap the transmissions. We know that we intend to have reduced by 2025 the new infections up to 370,000 new infections. By now, in 2023, we know that we are still at 1.3 new infections. And we know the interventions that work, we know what needs to be done. This is supposed to translate into at about 82% reduction at country level by 2025 compared to 2010. We need to do much more. And one of the things that we need to do, especially in this new generation condom programming, with this cost-effective intervention that we know that works together with the others, we need to be more intentional and look out for the communities that are most affected and have the communities reach them. In this, we know that the communities and the subpopulations, because of the dynamics of the pandemic, they are spread across. But we need to find out, and we have at least, if we have an opportunity to know who they are, where they are, why they are most at risk, and what they do that puts them at risk, and when do they do those activities that put them at risk. Then we can actually also map out how to reach them, and then how many and how much is it going to cost us to actually get there. So in precision planning, it's important for us to do more targeting, that's the interventions to be more people-centered, have consensus and ownership and mutual accountability of the interventions, and then focus more resources to where the biggest burden is. And this requires us to have more critical granular data and set behavior targets, if possible, to the different subgroups at their different locations and the different subtypes, not just in general form. Otherwise, when we look at the general forms, we get more blinded and we may not actually hit the target. So if we want to accelerate our movement to the target, we need to do that. So the CNET is one tool, is an innovative tool that comes in to help us quantify the need based on the condom needs for the countries, based on the behavior targets and the subpopulations that exist within the communities or within the country that we know they have different needs and use profiles for the condom. So we had 1999 targets by 2020 that led us to the need of about 20 billion condoms in the low and middle income countries, and we needed to improve the condom use up to 90%. Among the high-risk populations. With precision planning, we've had this broken down into finer or smaller subpopulations, and we know that the target was set up a little bit to the 95, but also even within the 95, we need to have the different subpopulations set targets uniquely different for them, for the different subpopulations. So in this, we know that things that are going to affect the behavior of the people knowing their status is important. Knowing the status versus the status itself, because we know as the status shifts, then the use and the approaches need to also be stepped up and different. Knowing the background prevention and incident scale-up of PrEP and other interventions, as well as the AGYW platforms and STI and unintended pregnancy prevention. So the CNET, what it does, it gives us an opportunity to know the total condom needs for HIV prevention, STI prevention, and FP prevention, taking into account the specific needs of the different high-risk populations that are categorized or identified within the different communities, but also giving us a general focus onto the public health impact or need of the general population and the contributions of the different interventions. So it allows the different governments and institutions to be informed by the data to specify and identify the priority populations that we need to target with the condom programming. Just like I started from above, we need to be more precise when we're targeting where the highest burden is where we need to put the resources. We need to review and accelerate, and validate the availability of the baseline information about the condom use profiles. Then review and validate the condom use baselines. It helps us set use targets for the different priority populations. That's which eventually gives us an estimate of how much is going to be needed for the different priority populations, but also the general public health approach. That's estimating the male, female condoms, but also the extra lubricants that are needed, among other things. But also, it also offers us an opportunity to check on how much of the condoms will be needed for free for the priority populations, and then those that are needed for commercial, that will be needed commercially, that can be accessed commercially, given the targets that you set, and of course, the strategic objectives of the country. And then from that, it helps you get a total market approach kind of scenario that you can work with, and then therefore enforce the different policies that can cause the market, force the other markets to grow more sustainably. It estimates the commodity quantities that you need, and then also factors in the cost at the manufacturer's level of how much you need. And then this is going to be helpful in actually estimating how much you need, and then you can plan effectively. And then estimates the wastage by the different subgroups, because you have, if you have the green data, then that you can actually get it. So in terms of application, once you have the priority populations and the targets that you are setting, that you set for the different subgroups to the different micro levels, and then you have the baseline data. So you really just factor it into the model. Then you're able to know how much lubricants you need, how much male and female condoms you need, how much of these would be free, and how much would you want to dedicate to the commercial sector, and so on. And then the cost that you need, therefore, to sustain your condom market for the different sub-communities and markets. Then with this, you can actually do an effective procurement plan, resource mobilization, advocacy, which is more objective, national strategy that is more people-centered and more focused on where you want to place your resources, and then more accountability and best needs. So we had an experience of the CNET. This is the second season of the CNET application in Uganda. But at this time, we took it to the next level of experience of having it done more collectively with all the stakeholders involved needed. And then with this, we're observing more benefits that we can actually exploit from the CNET beyond just the quantifying the needs and the condoms that are going to be required or the costs. So for Uganda's case, this is just really a short story of Uganda. So we also started the same way, identifying our population.
Apologies, we are running late, so perhaps the main points will be most appreciated. Thank you so much.
So identifying the communities that are needed, and of course, the user profiles, just like we indicated, which is in regards to baseline. So broadly, these are the ones. And our NSP identifies the different subpopulations at most high risk. And then just like you see them there. So we know that key populations are then using up more, having the higher demand for condoms compared to the other subgroups and the purposes. So with that, then you can have your jointly established estimations and assumptions that feed the model for the different subpopulations, and then also the general kind of need and groups that you have in terms of their numbers that you have within your communities. These need to be agreed on jointly. So what benefits did we observe beyond just quantifying the condoms that are needed? One is it led into having a more people-centered costed strategy with the population-specific behavior targets well set. And this has guided more objective coordination and stronger stewardship, inclusive of all the subpopulations that we know need to be targeted, because already we set the different targets for each. So we needed to bring them together so that we can coordinate and have a much more stronger condom program implemented. Total market vision is set with a strategic implementation plan, increasing the commercial sector to at least 35% as a vision that was set objectively. And this has been has seen more interest into by the commercial sector, where we have now more innovations by the commercial sector, knowing that they have a market to occupy, a market space to occupy, bringing together the innovative ways of reaching the wider market. A transparent and harmonized resource mobilization that's guided by the cost and gap analysis that comes out of the Senate. This has led to a more timely commitment of resources by the different big sources of funding, but also give an opportunity for more advocacy for even domestic funding that's now currently ongoing. This we've seen a Global Fund, PEPFAR, and UNFPA committing more resources much earlier to make sure that we do not have a gap, to cover the gap that is existing, but also as mobilize and advocate for more. Another one is more of an objective and accurate procurement planning and supply planning managed. So this has seen us have condom and lubes for the different subpopulations within and outside, like external procurement into the country, but also movement to the communities a bit more in a more coordinated way, have a coordinated pipeline, and among other things as we monitor the commodities. Then a differentiated supply chain management system and distribution planning that's introduced with effective targeting. We introduced a last mile distribution initiative to GIS mapped hotspots, and this fosters even further micro planning at subnational level and implementing partner level, with now the different sub-communities or subgroups knowing that they need to map their hotspots so that they can get resupply. So there's less stigmatization, there is less dependency on two other external factors, because the commodities now move directly from the warehouse directly to the community, the way it's supposed to be, and then this fosters even more micro planning at that level. The hotspot mapping, I've talked about this, that is now targeting the different sub-communities of highest need or risk, causing modifications, and even the national distribution strategies and guidelines to ensure that there's more community involvement and less more systems affecting transmission of condoms to the last mile. More people-centered.
Unfortunately, we are getting out of time, and the interpreters may. Thank you.
Yeah. So then tool factors in commodity planning into consideration of the other HIV prevention and SRHR intervention packages, and this enhances more integrated SRH at programming and service delivery level for the different subgroups. Thank you very much. This is what we have as sharing the experience of Uganda's case on how much you can do beyond the quantification, but also to exploit more benefits of the Senate. Thank you. Over.
Thank you, Wilberforce, on putting that into, operationalizing and showing how Senate was used for precision planning. I would like to thank you all, and apologies for going over time. I think some of the questions have been answered in the chat, but I did want to, if possible, hand over to Susie to give us a couple of closing remarks before we all step out. But also just thanking all the presenters for this marvelous work. Susie?
Namwinga, what a great discussion. I learned a lot. I also found the questions in the Q&A section very compelling. I went to answer a few, but I thought maybe it was not my role, so I hesitated a bit. But the thing that I want to take away from this is that there's a strong interest in some really fundamental questions about how condom programs expand, improve, adapt to new opportunities, etc. And yeah, I suppose there's a hope here that through UNAIDS or the Prevention Coalition, that we can continue to have some kind of a community of practice or something, because I think condom programs are one of those intervention types where I think people think that they're more simple than it actually is. I think there's quite a bit of complexity, and I refer, to some of the earlier work that undertaken by Man Global Health and others that were pointing out that in a lot of instances in a lot of countries, demand creation has stopped in the most part. And so for those people that are asking questions about why more people aren't using condoms, I think it's important that we start from some fundamental concerns, which is why or how would people use condoms if they didn't know about them or didn't know about their benefits? So an important first thing that I think it's great for all of us to discuss are these really critical issues around the ongoing work on demand creation. It's always been a need. The need will always continue, and there are new ways to adapt demand creation and improve on our efforts. But yeah, so it's just been a great discussion. Thanks to all the presenters from Global Fund perspective. I hope it's really clear our interest in supporting strong and sustainable condom programs. And yeah, back to you, Namwinga, on this question of if it's possible to kind of have some kind of an ongoing platform for us to keep talking to each other and learning from each other on the theme of strengthening condom programs. Thanks, everyone.
Thank you, Susie, for your comments and for wrapping it up so nicely. I want to thank all the presenters again, and also a special recognition to Prof. Sheila Tlo, who also took time and has been attending this webinar as she's the chair of the Global Prevention Coalition. So thank you to her. And to all the presenters, and most importantly, thank you to all the participants who have shown such interest. And for us, it has shown us that we need a space for condoms. The condom conversation needs to continue, and we need to keep generating information and data around condom programming. And I think, Susie, we had this conversation about how to better monitor data around condom programming beyond the facility. And I think this is what this webinar is telling us. We don't have enough of that. We don't have enough information around condom programming. So we will have the slides to share out to everybody, and we will put our heads together to think about how we can continue this conversation in this space to share lessons around condom programming, which translates into strengthening condoms, in an integrated manner. So really thanking you all for your time, thanking the presenters, and thanking the participants, and your active engagement throughout this webinar has been fantastic. It's energized us to keep going along with you. And Paula, also thank you very much for your kind opening remarks. With that, I would like to say bye, and thank you again, Susie, and the Global Fund for rallying around the Condom Strategic Initiative. Thank you very much, everybody, and have a great evening. Bye-bye.
Thank you, Namwinga. Great evening.
Thank you.